This module will review the relevant anatomy and procedural steps involved in safe and effective drainage of a peritonsillar abscess. The peritonsillar space is a potential space between the tonsillar capsule and the muscle of the superior pharyngeal constrictor. During tonsillectomy, the tonsil and its capsule are removed, allowing us to see into the space that will be accessed during this incision and drainage procedure. Peritonsillar abscess presents as a bulge of the soft palate, lateral and superior to the tonsil, often with deviation of the uvula to the contralateral side. Palpation of this portion of the palate with a gloved finger will often reveal a firm, fluctuant area. Peritonsillar abscess may be diagnosed clinically and CT scan is not required. However, if a CT scan is performed, a rim-enhancing fluid collection will be seen in the peritonsillar space, often displacing the tonsil medially and anteriorly. If an abscess is strongly suspected based on history and exam and/or CT scan, incision and drainage must be performed. The procedure begins with reviewing the steps of the procedure with the patient and obtaining informed consent. The primary risks are bleeding and aspiration of blood or pus into the airway. A list of equipment needed for the procedure is shown here. The only medications required are topical lidocaine spray and injectable lidocaine with epinephrine if available. Lidocaine can be 1%, 1.5%, or 2%, and epinephrine can be 1 to 100,000 or 1 to 200,000. Obtain a headlight and ensure there is a suction setup available and functioning with either a Fraser or Yankauer suction tip. You will need tongue depressors, a kidney basin, and tissues. You will also need a 25 gauge or smaller needle on a 3 cc syringe, an 18 gauge needle on a 10 cc syringe, a culture vial to collect the purulent aspirate for culture and sensitivity, an 11-blade scalpel, and a curved hemostat. The patient is placed in a seated position and given a basin and tissues to use as needed. A tongue depressor is used to retract the tongue and expose the tonsil and soft palate. A 1-second spray of lidocaine is applied to the soft palate mucosa just lateral and superior to the tonsil. Topical anesthesia will be obtained in 30 seconds. Lidocaine is then injected into the mucosa along the superior and lateral border of the tonsil at the intended aspiration and incision site using the 25 gauge or smaller needle and 3 cc syringe. The 18 gauge needle attached to the 10 cc syringe is then obtained. Starting at a site just superior and lateral to the superior portion of the tonsil, the 18 gauge needle is advanced while directed straight posteriorly. Do not angle the needle laterally. Once the needle tip is just deep to the mucosal surface, pull back on the plunger to create a vacuum in the syringe. Advance the needle tip until pus is aspirated. Do not bury the needle tip more than 2 centimeters to avoid damage to underlying structures. If no pus is aspirated by the time you reach this depth, you may need to attempt aspiration at another site more superiorly or inferiorly along the tonsil-soft palate interface. Aspiration is then followed up with mucosal incision and opening of the peritonsillar space to allow continued drainage. An 11-blade scalpel is used to make a 1 to 2 centimeter incision just through the soft palate mucosa at the site of aspiration. A curved hemostat is then used to spread into the peritonsillar space, breaking up any loculations and expressing more purulent material. The procedure is then terminated. The patient may gargle and spit but should not eat or drink for 1 hour after the procedure to allow resolution of anesthesia. Many patients will have substantial symptomatic improvement after successful drainage. For those who are tolerating PO intake and appear well, discharge may be considered with PO antibiotics and close outpatient follow-up. If there are any questions, difficulties, or issues with management of a patient with suspected or confirmed peritonsillar abscess, the ENT physician on call should be contacted and will be happy to assist. Thank you for your time and attention.